Lovely to see you in the room and online. I'd like to start the proceedings this afternoon by asking Emma Walk, Associate Professor Emma Walk, to come and provide our acknowledgement of country. Thank you, Emma.
Hi, everyone. Just want to say, Jananali Mer Jagi Jugana, we stand on solid ground. And today we're on the beautiful solid grounds of the Widjabul Waible people of the Bundjalung Nation. And we are really fortunate, obviously, to have today and to have this centre and to have this opportunity as a group of people that can come together and learn and teach and share things. But I also think that it reminds me very much of how we are in our community and what my elders have been like and how lucky I am as an Aboriginal woman to have that opportunity to learn from my elders and from the people in the past. And so thanks everyone for being here today.
So welcome once again, and thank you, Emma, for that acknowledgement of country. I'd just like to reiterate that that lovely sentiment. I'm so lucky to be in this beautiful part of the world in Northern Rivers, and I also acknowledge and pay my respects to elders who have cared for community and country for so long, and we really value all the input from Emma and the team and others here online and in the room. So good afternoon, everyone. It's such a pleasure to welcome you here to University Centre for Rural Health. In case you don't know me, I'm Vicky Flood. I'm the Director of the Centre, and it's wonderful to see the range of people that we have in the room and online. And today marks the inaugural Professor Stephen Lee Lecture in Ethics, and we're really excited to be hosting that first lecture as part of the series at the Centre, along with Sydney Health Ethics and the team. And we'll hear more from Catherine and the team, and we just really welcome all those people who are visiting us for this lecture. And particularly like to thank Teresa Lee for her generosity in supporting this lecture series to occur across here at our site in Broken Hill and then in Dubbo and Orange later in the coming years. So I look forward to seeing how that develops into the future. We're very excited that Professor Jenny May, National Rural Health Commissioner, will be providing this lecture for us today, and thank you so much for coming to visit us, Jenny. So just a little bit about our centre in case you don't know us. We're supported and administered from the University of Sydney. We're one of the 3 rural clinical schools of the University of Sydney and working as a rural clinical school and a University Department of Rural Health. And in 2026, we celebrate our 25th anniversary. So we're really excited to be kicking off that 25th anniversary with this lecture today and to be sharing some of those celebrations with yourselves. So there'll be more on that to come as we progress through the year. And our work in Northern Rivers has a deep focus on education, research and workforce development. And we work very closely on this topic of health equity, working alongside the communities where we live and where we work and serve. We are Commonwealth funded from the Rural Health Multidisciplinary Training Program, and we work with multiple tertiary institutions, so about 20 different institutions. In 2025, we hosted and supported around 700 students from allied health, medicine, nursing, dentistry, pharmacy, across the footprint of Northern Rivers, and our shout out to our great clinical educator team who do so much important work there. We also do a lot of research that is priority driven around local needs of the population, and we're deeply embedded in local communities, and you'll hear a bit more of that work from members of our team as we talk in the panel. The theme of today's lecture, Equitable Access to Healthcare in Rural, Regional and Remote Australia, speaks directly to our mission and our experience. Questions of equity, place, access, workforce and ethics are not abstract here. It's part of our daily experiences living and working in Northern Rivers. It is therefore entirely fitting that our inaugural Stephen Lee Lecture is by Professor Jenny May, AM, Australia's National Rural Health Commissioner, someone whose career has been dedicated to rural health, leadership and advocacy. Professor May was appointed in 2024 as the National Rural Health Commissioner, and she has a background as a rural general practitioner and educator with more than 35 years of experience. She is a fellow of the Royal Australian College of General Practitioners and the Australian College of Rural and Remote Medicine. In 2016, Jenny was appointed as a member of the Order of Australia for her significant service to community health in rural and regional Australia. And in her current role, Professor May provides national leadership on rural health policy, workforce pathways, and equitable access to safe, high-quality care for rural and remote communities. Her perspectives bridge clinical practice, education, policy, and lived rural experience. We've been chatting about her experiences living in Tamworth and beyond, but she has many lived rural experiences. So we're honoured to have you here today, Professor May, delivering the inaugural Stephen Lee Lecture, and we're very much looking forward to that, your address on equitable health access in rural, regional and remote Australia. But before we pivot to Jenny, we're going to hear from Dr. Catherine McKay, who will introduce Sydney Health Ethics and talk to us a little bit about the connection between Sydney Health Ethics team and this Professor Stephen Lee lecture series, and introduce Teresa to us as well. So welcome, Catherine.
Thank you so much, Vicky. It's such a pleasure to be here, and I think I can say that on behalf of my Sydney Health Ethics colleagues as well. We're absolutely thrilled to be visiting Northern Rivers. Sydney Health Ethics is a teaching and research center in the School of Public Health in the Faculty of Medicine and Health at the University of Sydney. We call it SHE. SHE focuses on the ethical issues across health, medicine, and the health sciences by applying approaches and methods drawn from the humanities and the social sciences. Our mission is to achieve a positive social impact by engaging in academic and public discourse on ethical and humanitarian matters related to all aspects of health and well-being. It's our absolute pleasure to be up here today for the Stephen Lee Lecture. This is the inaugural lecture, and this lecture is delivered in memory of the contributions to clinical education, mentoring, and ethics in the field of medicine made by the late dermatologist and clinical professor Stephen Lee. Professor Lee graduated from medicine with first-class honors in 1974, and he became a fellow of the Australian College of Dermatologists in 1981. By all accounts, Professor Lee was dedicated to his patients and to his students. He established a practice in the inner west of Sydney and a satellite practice in Taree, where he spent 2 days a week, every week, for 17 years. He was appointed as a visiting medical officer at both the Royal Prince Alfred Hospital in Sydney and Concord Hospital, at which he became the head of Department of Dermatology. And through these appointments, Professor Lee looked after his patients while also teaching and mentoring students in dermatology, which was a central passion of his. He became involved with the Australian Medical Association, becoming the first dermatologist to represent his specialty on the AMA Federal Council. And in his time with the AMA, he was a strong advocate for ethical behavior by doctors and social justice for patients. In 2009, Professor Lee was inducted to the Order of Australia for service to medicine in the field of dermatology as a clinician, mentor, and educator, and through roles with professional organizations. Right up until the end of his life, Professor Lee believed that life was beautiful. His guiding principle through his 50 years as a doctor was put patients first. His colleagues report that his patients would often mention what a wonderful, warm, and compassionate doctor he was, and comment on his remarkable sense of humor. His empathy towards his patients was legendary, and he was an excellent communicator. In Professor Lee's final years of life, he was on the receiving end as the patient of kidney dialysis. And this made him realize what being a good doctor really meant. It was his wish that through this lecture series, future generations of medical doctors from all walks of life could learn the importance of ethics when deciding optimum outcomes for patients and always put patients' interests first. And we were really excited to be hearing from Professor Jenny May on equity and equitable delivery of healthcare in rural places, because it seems a perfect combination of the key passions that Professor Lee had of education, of patients, and clearly a dedication to rural health. It's also my pleasure to introduce to you Teresa Lee, the widow of Professor Stephen Lee and the generous donor who's supporting this lecture series. Teresa, would you like to come and say a couple of words?
Thank you very very much for all coming along today, and thank you to Dr. Catherine for organising. She's worked, I think, very hard on bringing you all here together, and it's wonderful to see so many of you here today in memory of my late husband, Stephen. Dr. Kate's probably taken a lot of what I've already prepared, so I'm just going to tell you two quick things on a more personal note about Stephen the man. It's interesting that you're celebrating your 25-year anniversary because it was 25 years ago Stephen and I first met. We met later in life, and he made the brave decision to fly from Sydney to Queenstown in New Zealand for a dermatology conference only 3 weeks after September 11, when many were unsure about flying internationally. I'm so glad Stephen took that flight because it was there where we met. On our first date, Stephen told me of his desire to write a book titled The Ethics of Love. Sadly, that book was never to be written, but my goodness, we lived the title, especially through his many health setbacks, which we endured together over the 22 years of our marriage. All I can say is that Stephen really loved educating and mentoring the next generation of doctors. He was a strong advocate for the term education rather than the term teaching, which is probably why he never became an examiner. He was a strong believer in equality. He walked the talk and bulk billed all his patients throughout his practicing life. He regarded his medical career as a vocation. And just on a lighter note, I'd like to welcome Bella to the fore. She's here today. Stephen absolutely loved dogs. Before we got our own dog, he used to chase other people down the street to pat their dogs. So he'll be delighted that Bella's here. He'll be delighted that we're celebrating 25 years, so it's a different anniversary. But he'll be delighted to see so many of you here today, people of all walks of life, here to appreciate the importance of ethics and the decision-making that we all make in our own fields and in life too. Thank you.
Thank you so much, Teresa. Without further ado, hand over to Professor Jenny May. Thank you so much.
Catherine. Look, thank you so much, and I'd like to start by acknowledging the traditional owners of this land, the Widjabul, Wirrabul people of the Bundjalung Nation, who are the traditional custodians of this land. I do pay my respects to elders past, present and emerging, and I'm really glad that we're sharing this event with Aboriginal and Torres Strait Islander people, and I hope that in the discussions we have about inequality that I privilege the importance of First Nations leadership in what you hear from me and in what I honestly and truly believe. I am so delighted, Teresa, that you're here, and I really thank you for coming here because as I've read about your husband, and I did meet him on one occasion that he won't remember, but or he, wouldn't have made any impression on him, but it certainly made an impression on me. And it is an absolute honour to present this inaugural lecture, and I hope that we honour his presence and we honour his name in our really trying to think a bit more deeply about the inequalities that we see currently in healthcare and what we could or should or might be able to do to the future. So I am going to indulge a little bit in giving you a little bit more information of my deep dive into Professor Lee's career and how it relates to some of the themes that I'm then going to go on to. I am going to paint a bit of a picture of inequality that many of you in the audience are even more expert in, but I think it's important as a scene-setting piece for those discussion about those ethical responses that we do have that picture. And then I'm going to talk about some trends of what I can see in healthcare going forward, and they're trends that those of us who work in the rural and regional part of Australia or in the sector really need to be having our eyes on. And finally, some opportunities and challenges that I really hope that we can grapple with. So what of the life and legacy of Professor Lee? Well, my understanding is, and it's great that Teresa's here because she can correct me if what I'm reading is not quite right, which is a bit of a theme. Exactly, and when you were talking about the waving finger, I felt right at home. So my understanding is that Professor Lee was born in southern mainland China, and that was at a time when China was nearing the end of a decade-long civil war, which was the impetus for a significant political and cultural change. And one of the many tragedies of that civil war meant that mainland Chinese families, such as Stephen's, needed to flee to Hong Kong. And by some estimates, there were hundreds of thousands of mainland Chinese taking refuge in Hong Kong. And by the mid-50s, it was believed that a third of Hong Kong's 2.5 million residents were actually refugees. So I ask you to think back to that time and to think about the tumultuous nature of that time. I imagine that in these formative years, his understanding of the importance of others and each other to assist the door to opening the opportunity for simple things like food and housing really probably cemented some of the social justice experiences that he had. So those are some photos that probably epitomised that time. In the mid-60s, by which time Dr. Lee's family had the opportunity to migrate to Australia. So in the mid-60s, Stephen had an opportunity to complete his secondary schooling years at Randwick Boys High School with the help of a kind Australian. So what does that tell us? That tells us that someone put the hand of friendship and support out to Professor Lee at that time. That was despite the fact, and that's why I've put in this slide for you, that the White Australia policy was in effect. And even though the government had been eroding that policy, it wasn't dismantled until '66. And it's important to know that the policy wasn't formally eliminated until a decade later with the Racial Discrimination Act. So you can see that I'm trying to paint a picture of the kind of Australia in which young Stephen would have arrived to. So in addition to the racism he may well have experienced, but also coming from a geographically small but rapidly growing economy of Hong Kong to the suburban landscape that would have been in Randwick. Stephen graduated, as we've heard, with first-class honours in '74 before undertaking his internship at Royal Prince Alfred and became a Fellow of the Australian College of Dermatologists 7 years later. I can tell you that in 2026, the chance of graduating from the College of Dermatologists 7 years after completing your medical degree is that big, all right? So people now are spending 15 years in that training continuum. So very different to the environment back then. And as we've heard, in his first years as a consultant, he split his practice between Sydney, Port Macquarie and Taree, travelling to see patients to stop them needing to travel to him. So in choosing to meet the need of rural patients and prioritising, as we've already heard, that person-centred care, didn't he just show us the importance of that connection with community? And my word, having looked after Taree for many years, the word on the street is the community loved him and they really appreciated the effort that he made. So in his later years, then he went on, as we've heard, to contribute through the AMA and through various committees. And just as we've heard, apparently he thrived, and I'm going to use the word teaching, but he thrived in the teaching experience because he chose to educate. And he did have a passion, as I understand it, for teaching and mentoring students from other countries and helping them integrate into Australia, echoing the sort of support that he received, or some of the support he may have received on his way through. But he didn't leave it there. He gave back and remained engaged in practice in the place he grew up. So he then returned as a clinical associate professor, as a visiting professor in the China Medical University in Shenyang in northern China in 2004. So you can see the pattern here about someone who gave back and gave back so regularly. So sadly, his story is a little unique in providing that guidance and support. Many people opened the door for him, and what he did throughout his career was open the door for many. And his contributions are enduring. So for many of us as health professionals working in the system, we do see, as he did, the inequality, inequity and access issues, with those other important layers that I'm going to name, including institutional and interpersonal racism and sometimes unhelpful culture. So now we'll move to a few facts. Think about health outcomes. Health outcomes in rural, they're long-term metrics, and obviously they comprise a number of different pieces: genetics, social determinants, service access, and risk factors. But if we look at it, what do we see? We see that gradient, the striking gradient. This is for a range of different conditions that translates into premature deaths under 75 doubling in remote communities when compared to major cities. Many of those are avoidable deaths. And we know that there are multifaceted contributors to them. I'm not saying that's all about healthcare access. I'm being honest and saying that's a multitude of things. But we know that that is the challenge, that is the bold-faced challenge that we need to look at. So second to that, it's important to note that while there are more First Nations people living in urban and regional areas than remote, the proportion of First Nations people living in rural and remote areas is much, much higher as a percentage than in urban. Can I draw your attention to the National Health Reform Agreement, which is a turgid 500-page document which was released publicly last week. Don't expect you to have written it, but I've just had a quick skim of it for you, and I'm going to give you a little piece of it because it is a piece of hope that I have in this mired area. And it's clause B54. It says, state and federal ministers and the parties acknowledge that racism and associated discriminatory practices create inequity within the Australian health system. They recognise the value of primary health care and First Nations leadership and name their responsibilities as system managers to ensure culturally safe care. This is the first time I have seen a high-level commitment that puts those words on paper. And I urge you to have a look at it and to consider that if our state and territory health ministers are signing this document, what they see as the actions that will emanate from making that statement. A quick word on the social determinants, and obviously I could give you slides on education, housing, employment and many more things. For the purposes of this lecture, I am not, and I'm using education as just one example. And that is, in terms of education outcomes, we know of the wide gap of completion of Year 12 between major cities and regional, rural and remote. We have some hope that the gap in remote has narrowed slightly between remote and major cities, but the gap remains significant. Let's move to health risk factors and what a complicated picture that is. So if we look, and this is my incomplete synthesis, and as I said, there is expertise in the room that would be able to tell me that I've left things out and that there are things that I have emphasised that shouldn't be emphasised, but it's for that scene-setting purpose. If we look at smoking, we look at drinking, we look at overweight and obese, if we look at insufficient physical activity and food insecurity, we see a greater representation of those risk factors, and again, we see a gradient between regional, out to rural and out to remote. Safety is another challenge. The rate of dying due to land transport accidents is 3 times higher in remote areas and almost 4 times higher in very remote areas. It is my children's lived experience that they've lost someone in their year 11 and 12 cohort. Each of the 3 children has lost a friend to a motor vehicle accident. It is my lived experience that that risk in terms of land transport absolutely translates to health outcomes and to, lost potential. Are these avoidable? It's hard to know, isn't it? Social factors play a huge role. We know that women who live outside major cities are 1.5 times at least to experience partner violence. And we know that people are more likely to be hospitalised due to domestic violence in rural and remote. And we know that all those things are significantly underreported. We know that the rates in terms of maternal and child health are different, but if I can point to some excellent work in this area, in this region, trying to close the gap in terms of low birth weight and making a difference for people for whom those are significant risks. But you can see I've put up there occupational and physical risk, and I've put climate change related risk. Now, what I'm doing is, I guess I'm speaking to the trauma and the recurrent trauma that I know exists in communities such as this. And it is understanding that that risk translates into mental health risks, cardiovascular risks, renal disease, and all-cause mortality. These statistics highlight the complexity of risk factor and the multitudinous need for interventions that work on individual risk factors. But this list is absolutely incomplete. A recent AIHW publication showed that for First Nations people, 35% of the health gap can be explained by the social determinants, another 30% probably by risk factors, which leaves us over 30% that is unexplained. Now, this audience has some concept of that unexplained, and it might relate to interpersonal trauma, impacts of colonisation, ongoing and generational racism, and challenges in maintaining language and connection, I would think. Our knowledge is incomplete. Our knowledge doesn't reference that 30% of risk factor that is unexplained. Despite these challenges, many of us choose and enjoy living in rural communities. Why? We report sometimes lower housing-related financial stress, and I agree in Lismore that's probably not a reality, so I'm not going there. Lower cost of living, that might be a bit debatable as well. Often a greater sense of personal safety, definitely more sense of belonging and connection to place. And that is the real piece that binds and improves health outcomes and improves risk factors in our rural and remote communities. These factors actually support health initiatives because trust and engagement are real things in rural communities. So how do we rate internationally? Well, let's just look at the box 1 overall ranking and go 1. Yes, we're there. So in terms of a health system analysis of 10 nations comparing performance, and you can see the domains of performance on that slide, we're number 1. Let's go home. Look at the one underneath. Access to care, 9. What's the scale? 10. 1 to 10, we're 9. Nothing to be proud of. Now, some of our bureaucrats who work at a national level would say, well, that's all about the fact that we live in a very large country. And they would say, well, look at Canada. Canada hasn't rated well either. So it's all about geography. I don't think you understand. However, I am pleased to say that the Commonwealth Fund dug a bit deeper. And when they considered their definition of equity to comprise both that geographic poor access and First Nations access, we dropped from 1st to 6th in the healthcare system ranking, primarily due to the inequity of our healthcare access in rural and remote communities. And do you see who our friends are down there? They're not to be too pleased with. So, let's dig into equity. So thinking about equity, what's the goal? I've just told you that the health outcomes for rural and remote aren't the same, and we've got vulnerable groups overrepresented in these. So the focus is often not on social determinants, not on the issues related to colonisation and oppression, and sometimes not even on the genetic risks. But often it's about access to healthcare. Okay, so we'll take it. Let's talk about access. Horizontal equity talks about the principle of equal treatment for equal medical need, regardless of characteristics such as income, race, or place of residence. That should be a help, shouldn't it? Because we'll just give the same thing to everybody, no matter where they are. And I guess the example that I'm going to use of that, of a horizontal equity type decision, is the bulk billing initiative. Okay, we'll just roll it out across the country. It'll work the same everywhere. Bob's your uncle. Vertical equity involves the appropriate unequal treatment of unequals, meaning that those with different health needs should receive different levels of health services and access. I think that's more what we're needing to talk about in terms of health equity. We need more. We have people who need more. We need it different. But we want vertical equity as well as horizontal equity. And if we just go with horizontal equity, I think that underlies the resource allocation dilemma that might be being had. So I'm going to make it even more complicated. I'm going to unpack health access, because in your mind, you've got a view of what health access is. I'm going to suggest to you that it's got a number of different elements. And in fact, health access and health access challenge looks different in Lismore than it does in Benalbo, and it probably does at Tippaborough. And why that is that I think there are 4 domains, and I'm not making it up, it's from the literature, but I don't understand it perhaps as well as you do. But availability, so that's partly about geography, but it's also partly about whether there's appointments. And if there's not enough health workers, then there's not enough appointments, so it's not available. I mean, it's available on paper, but it's not actually there. Acceptability, that relates to the personnel, the community. Is it confidential? Is it women's business and you've got to see a bloke? How does it work? Is it acceptable? Is it appropriate? Is it not only culturally safe, but are we being offered a virtual service, whereas in fact we need a face-to-face where we need the laying on of hands? And finally, is it affordable? And much of the discussion in Australia in 2026 relates to affordability. Now, it's not just affordability at the point of access. For rural and remote communities, it's affordability of connectivity. And I would suggest to you that the argument about access to connectivity, particularly in remote Australia, has moved from it's now available if you've got $139 flag fall with Starlink. So you can get it, but it's about the affordability. So we've changed, if you like, the elements of access. We've got it, it's physically there, and to be honest, I don't know your experience, but it works better in remote than it works metro. So good. However, because it's owned by various international magnates, our capacity to influence price may be somewhat limited. So hopefully what I've done is painted a picture for you of inequalities in health outcomes and the complexity in that. But then moving to health access, and that's really the dilemma that I think we think of most in those of us who work in the health professions. So it's telling that often when we think about access, and particularly when we think about access in rural, we think about the number of health professionals and whether they are there when we need them. So let's think about New South Wales, and let's think a little bit about Northern Rivers, if I can. So most people who don't live in the Northern Rivers would think, oh, they're all right. Lismore's an MM3, which is a fairly large town, and it supports both primary and secondary care services. We've got a lot of discrete type services that are happening all over the town, and it does act like a catchment, so people coming in from across the way who are all coming in to Lismore to get their care. I think it's I mention that because what I'm going to show you is that as we go down that funnel, we get to less and less health professionals, but most importantly, if we get down to MM5, and your MM5s are Benalbo, Tabulum, Mumblegum and Kyogle, just for a few. I know there are others, but can you see that all our health professionals, so registered nurses and midwives, allied health professionals that are APRA registered and medical practitioners all dive at MM5? And I'm going to suggest to you that those towns, so those 1,000 to 3,000 towns, are ones that we really, really need to keep our eyes on. Because if I go back to the slide before, in New South Wales, 604,000 people rely on those services. Not totally. Remember what I said about catchment? Absolutely owning that people who live in an MM4 and 5 would be travelling into an MM3 and there'd be hub and spoke and FIFO services. Not saying this is the whole picture, but just trying to give you an idea of the size of the number of communities even in New South Wales that are MM5 and the importance of supporting a primary healthcare service in places like that. Now, I'm a believer that some of the answer will lie in an integrated or monopolised service, thinking about sort of an MPS-style service where we aggregate services or health professionals who are able to work in disability, who are able to work in ageing and in acute and primary care. But that's my bent from looking at these numbers. Okay, so I think I've painted the picture and given you the sense that maybe I don't think we've got an equitable health system right at the moment. Work to be done. But let's now look ahead. And I'm going to borrow from this New South Wales health document and again commend it to you. It's been on the net since 2024, so you might have seen it. But interesting, New South Wales Health, somewhat surprisingly, I think, commissioned CSIRO to do it. So I went, oh, okay, let's have a read of this. So what it's done is try to really think forward for us and identify what the mega trends that they could see in late 2024 that are likely to impact most on the healthcare workforce going forward. And they said 2040. I think it'll be even more different by 2040, but let's go with it. So let's look at the first one, limitless care. I think we're all experiencing something along that line, and the traditional boundaries of the health system are expanding rapidly, and it's giving rises to changes in how, who and where services are delivered. The dilemma we will have is working out what are the core, important, fundable services that government should be providing in this atmosphere of limitless care. Now, that's limitless care going into health and social care, and we, and those of us who work close to communities know the value of some of those services, but they're also going into very disease and discipline-specific care, and that is the profusion of online and telehealth providers that are providing very fragmented care, but increasingly an important part of our health system. One of my colleagues was telling me this morning that she was admitting that she'd gone onto a telehealth provider yesterday to get a medical certificate for her daughter, which was required for school, and that the only way that she thought she could get access was to go to one of those things and put in the details, and 7 minutes later they split it, and $50 later out spits the medical certificate. That's just giving you an idea of how the boundaries of what we would have previously considered a privileged conversation about illness or wellness, that is now moved to a commoditised tick and flick exercise online. So the boundaries are moving. So how are we going to work out what's core, what government should fund, and what care should we be expected to receive? It also goes into the argument around convenience care. So should we have after-hours urgent care centres for which people can present when it doesn't suit them presenting in hours? Some people would say yes, that's my access to healthcare. Some people, particularly those of us who live with a constrained workforce, would go, no, sorry, you'll just have to work it out to come in hours because after hours is for urgent care. But can you see how those discussions are so important, and we could use our health budget on convenience care, but convenience care in Tibooburra is going to need to look very different. Let's look at the next one, and it's a positive one. Empowered consumers, engaged communities. Very clearly, the preferences, expectations and behaviours of health consumers and carers continue to evolve and have an opportunity to shape the system. There are huge opportunities to provide information, improve health literacy, create cultural safety and engage communities to be involved in their healthcare. And that is part of what the future looks like. Equally, the concern is that particularly online modalities will result in misinformation and lack of trust in communities, where we have opportunities now to amplify misinformation, which eventually undermines sources of truth and trust. in both people and in information. So that delivery of, or balance on the delivery of information and health information is now contested. What's our response? How do we empower people and communities to make good decisions? As Professor Lee wanted to do, how do we provide person-centred care, but at the same time manage the information flow so that we provide information that is credible and evidence-based? At a community or regional level, the changing directions of individuals or groups may be a broader reflection of their sense of connection and belonging. Mass personalisation, which is the little one in tiny print, is hugely opportune. It will mean that we will have tailored genetics, genomics and various information on our risks that will make our care deeply personal. It will enhance our treatment, it will supercharge prevention, and it will open the door potentially on good health. Equally, that information, if it's in the hands of your insurance company or your bank, may not be so helpful. So control of the information flow will be a very contested and important discussion to the future. Augmented care. AI, robotics and other digital solutions, hugely opportunistic, and I'm going to talk a little bit more about it, about the future of an AI-enabled healthcare, of which they are many. It is my comment that the robotics bit and the laying on of hands and procedures, I think, will be one of the last things to go. If we think about showering Mrs. Jones in the nursing home who has a fear of water and doesn't want to be in the shower for any period of time, and you have to take her left sleeve out of her clothes first because she's got a sore right shoulder, robotic care is going to be slow in picking up on all the nuances about how to deliver safe care to Mrs. Jones. So that's my comment, is that one of the things we are is unique, and AI and the digital revolution is certainly going to pick up on high volume, repetitive tasks quicker than it is going to be doing on the really personalised aspects of care. So how do we, in an age of environment of workforce shortage and an ageing population with increased complex needs, how are we going to balance about the human-to-human connection and the use of this wonderful augmented reality? And I guess I've covered prevention potential and its steroid-induced capacity further on, but in this audience, obviously volatile world is the biggest one, and the one that in 2026, on whatever the date is, March the 26th, while we're waiting to see what the diesel opportunity, how much diesel there's going to be at the pump in about 3 weeks' time. I mean, let's think about the challenge, particularly to rural and remote communities, of the volatile world that we live in. Obviously, this community's dealt with the enduring and challenging effects of climate change and will continue to, changing disease patterns, but it's now those global disruptions that I want you to put into your back pocket and think about. How are we going to manage self-sufficiency in our supply chain and in the sovereignty of the things that we need to be sovereign? Are we thinking about that self-sufficiency in the way we go forward? What's the role of government in managing the volatility ahead? And are there important considerations? And this is where I'm asking you to think about the social justice that I think we need to be talking about first. So it is our remote communities that have diesel power generation that need the diesel first. If they don't have power, they don't have internet, they don't have food, and there's no freezer or fridge to keep the immunisations at the right temperature, the implications for fuel shortage in remote communities is huge. And it does relate to all those other determinants of health that we talked about, not just health access. So we're getting there, all right? 2 things ahead. AI. The next frontier is AI, and I'm going to suggest to you it's actually, AI is already here, it's AGI that we're most needing to engage with. So that's that pivot point where self-evolving AI is able to better itself, and it's likely to match or surpass human capabilities across all cognitive tasks. It's going to think, it's going to problem solve, it's going to prioritise, it's going to decision make, and it's going to review. Okay, so it's got the capacity to reflection. It's not about data aggregation, it's not about analysis and word planning tools. This is about decision making. This is the clinical decision maker that is on the horizon that will be problem solving and deciding your care to the future. There is some debate about when. Some people think it's almost here. 2026 to 2036 is what I've read. And that some large language models already have quite significant bands of cognition. But it's that total package that I'm talking about that's not quite here. Now, what's not in dispute is that there is currently a race on to concentrate AI and AGI ownership in about 6 companies. The decisions they make in terms of access, equity and values are being based on current market and global forces, rather than a belief in the individual value and rights of minority populations. It is disruptive but not unreasonable to think that tomorrow's health system will be using AGI and will be unregulatable. Current regulatory systems expect respect for national borders, accreditation and training systems that are controlled and managed often by membership-based organisations and collectives of practitioners and institutions, like governments. I won't speculate anymore, but simply identify that the market concentration may follow a path to profit, not to meet the social contract of health in communities. What we don't doubt is the interdependence that tomorrow's clinicians will have on AI. There'll be tools and capabilities that we can't even dream of. The AI clinical assistant will be an intelligent and adaptive one, and it'll be very reliable. It won't charge for after hours or lodge complaints. It'll have predictable maintenance schedules, lifespans and replacement costs. It'll be updatable within moments. And these tools hold equal promise to overcoming the tyranny of distance, as I suspect roads, radio and planes did in the recent past. It does expect that connectivity that I mentioned before, and that's a long way from the current reality that we're talking about with respectful data custodianship and data sovereignty that I'm suggesting will be very hard to quantify and even more difficult to enforce. Rural communities and First Nations people are particularly vulnerable to having little choice in the use of AI in their health service delivery, where that care is not offered in situ by trusted providers, and I hope that will be part of our discussion this afternoon. Globally, communities are contributing data without explicit permission, while the data is monetised and sold back to service deliveries as part of large language models to provide updated clinical support tools. So the equity it promises to smooth will only come if there's an intervention with funding and infrastructure, and will only come if we humans are properly educated and trained to enable it. Currently, the shaping of this technology is not being done in not-for-profits or community-motivated health schools. Who's going to pay for it? Who's going to be credentialed to use it? There's no doubt that it will improve efficiency, access, and convenience of care, cater to diverse needs, and open new ways of working. However, I guess this is the good bit. At what level are we going to empower individuals? The question is not, will it happen, but who will have access? I heard yesterday, 70% of general practices have at least one practitioner using an AI scribe. All right, the future's here in terms of that particular piece of technology. And I heard yesterday that it's really easily hacked. And who knows where that secondary data goes? Finally, and more positively, a word about health education in this near future. If we could distribute the skills and capacity in our rural workforce, it's clear that we could focus on care close to patients, focus on acceptability to clinicians, to patients, and First Nations-led training. That means we better select for diversity, we better think about training in place, and establish that scope and expectations with population need. It's in these activities we can signal to the health system the value of locally based care, which reincorporates generalism, and we bring the AI to the generalist. It's what you're already doing, but I'm suggesting you need to do it on steroids. For a rural career, we know what the biggest predictors are. We need to actively seek students with rural background or connection, or place-based connection. We need to offer them immersive rural placements for at least 12 months. And thereafter, we need to support their postgraduate and ongoing training and support them with the jobs they do to ensure that they provide the healthcare that communities need. Like Vicky said, we are very grateful for the investment that we've got with the University Department of Rural Health and Rural Clinical School. And Lismore is implicit proof that you can provide high quality training beyond the city limits. The next challenge you've got is the exact balancing of place-based one location education for the majority of training versus multiple rural placements over the course of a degree. And I don't think we know the answer to that. Clearly there is serious value in offering metropolitan students opportunities in rural settings, and there's ample evidence of multiple strategies being required. It is my belief that we can encourage people to manage uncertainty and hold the complexity if we train them in a generalist environment. Now, I'm speaking absolutely equally about nursing and allied health training. I'm speaking about a rurally inclined workforce. Also, given the age of our students and our desire to recruit more diverse cohorts representative of our population, and I'm thinking particularly of First Nation students, the capacity to study full-time is greatly reduced. So, place-based learning, possibly sponsored by an employer or in concert with them, is obviously a part of the future, with the challenge of work and learning as somewhat interchangeable. Interesting, some of our vocational training programs have always been versions of Earn and Learn, and Aboriginal health worker training is a good example. But let's be bold. Should we be looking to part-time CSP places, extending course completion times, modularising courses, supporting employer sponsorship? Should UDRHs be service providers for all students in place-based learning as more and more courses go online with students selecting their own placements? Many of our communities would like that, but also many of our communities are unable to support small cohorts year after year. So why do we do that? Why don't we run a pharmacy course every 5 years and run a cohort through years 1 to 4 and then start again? Or even go to a different place and run it? Why are we wedded to this model that we have to have the same course running every year in the same place? You know, it's not written anywhere that there's any evidence that that does anything but makes it efficient for your teacher. And if we diversify out the teaching, then my comment is, or education as Teresa or Stephen rightly put it, aren't we in a much better place? And aren't we in a much better place to provide those career opportunities for those that live in smaller places? But I think the other significant challenge that we need to face is how we're going to marry the human touch, empathy, knowledge of pain, of disappointment and profound joy, of loneliness and doubt, of knowing and being known. How are we going to work out where to put the human when we're on a trajectory to outsource the dispassionate investigator, prescriber and monitor? And hark back to what I said earlier. What's the component, the important thing we know about communities? Connection, trust. How does that work? So if we see these things as important, and I'm sure we do, then I think we must take the lead in ensuring that the models of the future, that those are equally valued and most importantly are considered as we rapidly evolve this story. Bachelor of Nursing in Charleville, population 3,000, 5 graduates. This is the 3rd graduation. All students have jobs locally. Bottom section, Aboriginal health worker training in Port Augusta, South Australia, Earn and Learn model. All of those participants have jobs and they have career skills escalator and career trajectory to consider. The UDRH movement is represented on the other side, and that's obviously just to reference the importance of that place-based infrastructure to do some of this stuff. So, training for the future, which I can't imagine, in a country where equitable access to health care is told to us as an underpinning value, but not always the reality. That's why we require a debate around ethics. But also, we need a coalition of the willing, and Professor Stephen was one of those coalitions of the willing, those with the appetite to innovate and probably a dose of opportunity. I hope we choose to honour the opportunities we've been given, just as Professor Stephen Lee did, and I'm sure he would exhort us to take on the challenge to make ongoing healthcare in Australia an equitable space. Thank you.
Thank you so much. That was really rich and very interesting. We have some time now for some questions directly to Professor Jenny May, and then we'll have a break, and then we'll have our panel discussion. So let me ask the audience, and this goes for the folks online as well. Are there any questions that you'd like to ask?
Thanks so much, Jenny. That was wonderful. One of the challenges that we have is that there's the requirement on us to take domestic-based students. And of course, we want to be thinking about students who are likely to stay rurally and work rurally. But of course, we had this wonderful example from Professor Stephen Lee of someone who had come from an international background and had a heart for working, broadly, metro and rural. And so it just creates this tension around this limited view on only sourcing our students from a domestic supply. I'd just be interested to hear your thoughts on that topic.
So you talk to an absolute reality, which is that 65% of doctors in rural Australia are often international medical graduates. So, you are so right. My comment is, I think, and again it comes back to a prioritisation of the scarce resource, I think you've got to decide what proportion, what's the best bet. All right, and what I've said here is that it's not a linear thing. So I'm saying to you, best bet, I'm pretty sure, is going to be a combination of rural origin or diversity of selection. I'll start there. And I think Professor Lee's previous experience goes to the diversity of selection. So you wonder how many of people who had Professor Lee's background would have made it into medicine with our system. So absolutely preferencing diversity, I think, is absolute. I agree with that. My comment about rural is a little bit more hedged, and that is that I think we've got to have a large proportion of the people we take into health courses who have connection to place. Now, I'm pretty open about connection to place being rural origin or rural origin plus, so I'm not saying that rural origin remains the strongest predictor, but it's not binary. We can't think of it as binary. I think we've got a challenge in being able to get enough students into footprint to have positive exposure, and the longer the immersion, the more challenging that is. So the challenge with end-to-end programs is that they are snapping up a lot of the resource of exposure, positive rural exposure. So can you see how we've got to do some balancing here to work out exactly, and there's one of people's colleagues here from the University of Sydney who's doing a PhD on metropolitan predictors of select, long-term rural return. It's going to be a really useful piece of information to put into the picture. So I wouldn't want to put a priority on international students who come with an absolute, I think, an honest belief that they don't know what their career trajectory is. And that's the, so saying that they are preferencing rural, they're preferencing rural for those that choose to have an internship and ongoing training in Australia, and that is their way in. Most of our 65% of international medical graduates in rural are coming in through pathways for recognition of existing qualifications and through things like an expedited pathway, so they're coming in qualified. So it is a different group.
I think there's a couple of questions online. I'm going to go to the online and then I'll come back into the room.
So from the chat, we have Jackie Scully asking, I wonder how much perceived status is a problem for recruitment of healthcare workers? How much a job in rural and remote is seen as less good than in the city?
Thanks for the question. It is my passion to elevate the role of rural practitioners. And that's my comment about generalism. Some of the work we've been doing is to elevate a subspecialty of general practice called rural generalism, and we are working hard to elevate that, and it's simply reinventing the wheel, all right? We're simply looking at practitioners who can describe breadth as well as depth, all right? So they've got a special skill, obstetrics, anaesthetics, mental health, but they've also work across a number of different environments. So you have to work in general practice or community care, you have to work in a hospital, and you have to have emergency skills. So can you see how we're trying to preference and elevate that wide range of skills? Now, we're absolutely invested in doing similar things in nursing and in allied health. It's just going to look different, but if we elevate the role of our rural practitioners, then we will deal with some of the status. Some of it is about money. I won't disagree at all.
Professor May, excellent presentation. Marco Giuseppe, I'm the EDMS for the Northern New South Wales Local Health District, rural generalist by training, via a tertiary hospital on my way here.
Yeah.
And one of the interesting experiences I had was just how inefficient tertiary hospitals are. So we look up to them as the bastion of incredible care. They're actually incredible resource drains on our system. So I'm all for doing away with geographic narcissism and all of that sort of stuff. I guess, how are the politics of this work in practice, right? So New South Wales Health says your new role delineation's out. You now have to have, 6 subspecialty cardiac anaesthetists to provide this service, and suddenly Lismore can't provide it anymore, just for an example.
Yeah.
How do I tell Royal North Shore they can't have their 10th ENT surgeon and I need one here instead?
So that's vertical equity.
This is vertical equity in action, right? And these are the sorts of challenging conversations that I think we in this room, we all agree, this is what we need to do. We have a whole bunch of metropolitan colleagues and colleges and other people that we have to convince that generalism is the way forward and that working towards that framework's important. How do we deprogram all of that?
I thank you for the question. You've nailed probably the most difficult issue, and it does pervade not only medicine but all of our health system. So my comments are, we do have to unbundle it. We have to change the perception of students and people looking at it, but how can we change that until there are models of people doing it that they can look up to? Because so much of the programming is happening by modelling. Problem number one is, how do we get jurisdictions in particular to fund generalists? Now, there is work going on, and be assured, we put out a guideline to the Council of Presidents of Medical Colleges on selection, which has talked about all the things that we've talked about to try and force the issue about making them select people who are much more likely to work in a generalist capacity and work for population need, more than rural, really thinking about what population need looks like. That's a small drop in the ocean. It is the culture issue in our health system, and it is propagated by the fact that metropolitan hospitals have an honest need to continue to feed themselves and feed the effort and to be at the forefront of innovation. And they do it well. So unfortunately, we're in a competition, and we're in a lopsided competition, because we're over here going, could we just, it's great to have that, it's great to have a machine that does that, but that's not going to be available to the person in Moree. So where's the middle ground about what are the core services that everybody should get access to and what are the add-ons that exist in a subspecialty conundrum. We need to educate patients because they've been told that if it costs a lot of money, it must be really good. And you've all seen it, or you've got relatives, you know. And the second thing is that generalism is not respected within colleges and within peers. So we've got a big job, but hey, we got to do it.
Thanks. It's the machine that goes bing problem. Another one online, and then we'll come here to the room.
Danielle White from Broken Hill is asking your thoughts about regulating for rural training for all nursing training and then allied health, as has happened in medicine.
I won't go out of my lane because I have two deputy commissioners, one with nursing and one with allied health. But can I just say, I think we can learn the lessons. I think we could probably do it even better. I do absolutely understand, though, that it needs to look different. And I'll use the allied health example. Obviously, advanced practice in physio looks very different from pharmacy or podiatry. All right, so is advanced practice, so getting back to the medical definition, we want breadth and then we want depth. All right, how does that work? So I think we've still got to nut out a scope and the way to best support, particularly allied health practice. I think we don't have the endpoints for nursing yet, that we need that privileged rural. And I mean, that's my comment. That's the only bit out of the lane I'm going to get. But absolutely work to be done.
Thanks, Jenny. I'm Yash. I'm an ED and retrieval specialist, and I'm the director of the training hub here. I think I've met you a few times before. I'm also director of IMG training, so obviously everything you speak about resonates deeply with me. My question is about STP funding and other programs like that the federal government has been funding for 25 years to increase rural doctors and specialists that work rurally. But a lot of these programs are still, most of that funding is still going to metropolitan-based colleges and hospitals. So do you have any opinion or options on ensuring that the funding actually goes where it is most needed?
An important fact of the specialist training, we're talking about non-GP specialist training. General practice is not in this, for this purpose is STP, which is the specialist training program, which is Commonwealth funded, only supplies 7% of the total pool of training places in Australia for non-GP specialists, 7%. So even if we ruralise the whole 7%, we ain't got what we need. We need 30% of that training to occur outside metropolitan areas. So the job is to use the 7% to leverage the other 23%. See the problem? So I've no doubt in the next iteration of the STP program, which is currently under review, that there will be a much closer focus on population need, and you can take that as code for rural, but it's not enough. So we cannot stop with just using STP. What we've got to do is get the jurisdictions and the colleges to value rural training, not as a pathway to metropolitan positions, but as a pathway to rural positions. And that's what I said, unless we get the jobs at the end, we can train, but if someone comes to the end of their training and they know that if they do a subspecialty year in rheumatology, they can get a job, but if they don't, they won't, then we've got a problem.
All right, we've got another online, another in the room.
Online. Philip Britton is interested in your thoughts about the way in which liberty, individual freedom to live and work where you will, patients and providers, interacts with government community obligation to provide services or achieve equitable health outcomes.
I'm not clever enough. It's such a good question. Maybe we get there in the panel. I don't know. This is why this is going to be real if we do have a fuel crisis. This is absolutely going to be real because it'll be a prioritisation of finite resource. So how much do we believe that we have a responsibility to support Australians no matter where they live? And how much are we going to prioritise disturbances, disruptions to our way of doing things? So if he's got an answer, I'm very keen to hear it.
Thank you. Thanks, Jenny, for your presentation. Annette Lenstra from the Rural Doctors Network. I have a question that's a little bit broader, I think, so please let me know if it is too broad and too much prediction requests. So we've got the Strengthening Medicare Reform agenda, which has been running for maybe 6 years now. My maths is not so good. So we've had the 4 or 5 reviews about a year and a half ago, and we've got the task force, the combined task force, which I personally think is a great approach to that. Combined with the current federal government having a bit of a trajectory for reform, how do you think that is going? How do you think that's going to impact rural equity towards like looking forward to that runway that the federal government theoretically has if they get the next election, so about another 5 or 6 years? So general.
So I don't know, is the bottom line. However, what I would say is the challenge that we had, say, a year ago is that, well, we've still got it, but it's a bit more nuanced, is we've got a quantum issue in terms of primary care. So we don't have enough people working in primary care. So I think the horizontal equity response that you saw late last year, which was the bulk billing incentive, is that government's attempt, and granted increased numbers in training into general practice, increased exposure, and more CSPs with a primary care focus. So I think we can see that they've had a policy intent to try and improve the number of practitioners in primary care. I think the debate is it enough? And certainly that wasn't a distributive measure, is my comment. I wait with interest as for the outcomes of the primary care reform. My input into it has been saying, show me how this can increase the capacity of rural primary care. So I'm all for increasing scope where we need it. Not necessarily MM1 to 7, but just like rural generalism, we will have an MBS geocode on rural generalism, for instance, MM3 to 7. So that's where we want people to work and use that skill. So love scope of practice change if it increases people's access to care. Most people who work in MM5, 6s and 7 work in teams because there's no one else, all right? It's not nearly as competitive, all right? We're all there to help the patient. There's not enough of us. So arguments on the ground about scope are really rare. So what can we do to support scope at that point, but not put that scope into the middle of Sydney where it will simply sap up the allied health professionals or the nurses or the pharmacists or whoever. Let's target the intervention. So that's the vertical equity.
Thank you. So I'm gonna ask a little cheeky question here. I'm from Canada, and I'm from one of these MM5 communities. My town was 1,500 people. And so what you would do if you had an emergency is you would call the ambulance and then you would start driving and you'd tell them which highway you were on. That may be something that happens here too. But I think I say that because I understand really clearly what the problems are. We hadn't had any general practitioners in my town for like a decade. We relied on nurse practitioners. But then too much on emergency health. So understanding the problem is one thing, and I think you did a really great job at outlining the complexity. But I wanted to ask, what beyond education can be done to help people?
Well, I think you've heard, in that small community, I'm a real believer in an integrated model. I'm a real believer probably in a salaried model of care, as opposed to using fee-for-service in Australia, which works well where where you've got practitioners, but it doesn't work particularly well where you don't. And we haven't had the same penetration of nurse practitioners into rural as you've had in Canada. So my idea is that you put together in one institution, I call it the one kitchen hypothesis. So you've got a multi-purpose service or you've got a place and you only have one kitchen. You don't have Meals on Wheels working in the community and then someone providing meals to the aged care unit and someone providing meals to your 3 inpatients. You put it together and you see what you can get. And it's that synergy and that professional support that you can get by aggregating professionals. Now, there's a size in Australia where we do almost completely rely on fly in, fly out. So many of our remote communities in Northern Territory, we are not talking about a long-term personalised residential presence in those communities. We've got registered nurses who fly out in tandem and, you know, might do half a week each and then they'll go back and the next 2 nurses. Now, we've got continuity over time if we can, because it's the same nurses who come back time after time and hopefully they're supported by staff who actually know the community and come out irregularly. And we do have a real challenge in getting that integrated, but I think that's our solution. In very remote, it's aeroplane. In drive-in, drive-out spots, as probably yours was, although having worked in British Columbia and been more isolated in British Columbia because of the weather than I ever was in Tom Price in Western Australia was a really interesting experience. We had to ventilate a small baby which we delivered for 3 days before we could get it retrieved. So I know that sense of responsibility that comes from the isolation that we've got. So is that a partial answer? I do think there are answers. I do think we just need to get a salaried model. We need to recognise practitioners to work at the top of their scope. We need the digital integrative piece to work for us, and it doesn't particularly work. It works well in different spots. But in the situation here, we're going to have a local health network record, we're going to have a GP record, we're going to have an ACHO record, we're going to have a pharmacy record. What's the source of truth? Sometimes it's the the medication record on my EHR, but sometimes it's not. And with a telehealth provider giving you your Monjaro by telehealth, and then you go to the anaesthetist at Lismore Base Hospital and they go, oh my God, this is an anaesthetic risk that's just arrived on the thing and there's no record of that anywhere. So we have an integrative problem.
Mm-hmm. Thank you. That is helpful. Any final questions? One online?
Cord asks for your thoughts on bringing down the state boundaries and improving services to aim to standardise generalist health services, saving money on reinventing wheels for delivery in rural and remote health.
Such a good idea. The people who are so disadvantaged by state boundaries, and I'll leave Tweed out of here because I know you've got that bit, but are people who live in remote. And if you talk to people who live in the middle of South Australia or, with the Northern Territory and Western Australian border, it's an absolute nightmare. So I don't think the states are about to be abolished. So we've got to find a different way of connecting. I'll tell you, I think we've got some opportunities though. And, we've got this new Thriving Kids thing. All the states have signed up to it. Let's hope we could get a record that was shared. Opportunity, maybe? I mean, I think that's how we've got to think. We're not going to get revolution. What does evolution look like? I mean, or is there a different way of integrating? Does Starlink save everything? And, we'll just pull it down from there, right?
Thank you so much. Let's have another round of applause for Professor Jenny May. Thank you.